So what we can see here is, see how his thumbs kind of look hollowed out right here? Both sides, muscle kind of looks atrophied. That's called thenar wasting. That's kind of one of the late signs of carpal tunnel syndrome. We had a couple of special tests that we talked about. First one is called Phelan's test. What you do is flex both of your wrists over, or have the patient do it. You can do it with them so they don't feel awkward. And you hold it for about 30 seconds. And if that starts to develop that same paresthesia they were talking about, you say, okay, it's probably that median nerve that's getting pinched through there. If it develops somewhere else, it's probably not what you're dealing with. It might be a cubital tunnel issue. Now, what's a positive test? Recreation of the symptoms, be it tingling, be it pain. What's negative? No recreation of it with about 30 seconds of compression. The other one that we need to pay attention to is called Tunnell's sign, tapping Tunnell's. What I do is I can take a reflex hammer, I can take my 2 fingers, use what a heavy book, just hit it. What I'm doing is I'm tapping very lightly on that nerve, and that should recreate exactly that same distribution. If you hit someone hard enough, you'll recreate that pain. But someone with carpal tunnel syndrome, they'll say, yeah, it kind of hurts sometimes in my hand. You tap that, it recreates exactly what they're dealing with. Positive sign for Tunnell's test. And lastly, we got that carpal compression test. It's also called Durkin's test, but I've never really seen that used in literature a bunch, so don't commit to be like, oh, it's not Durkin's. What that one is, it's kind of like a modified version of Phelan's, where I just hold their hand out. If like the patient only had one arm, they can't do it. So what you do is you sit and hold with your thumb and you compress right where that median nerve is going through that carpal tunnel and try to recreate the symptoms that way. Sometimes people will combine Phelan's as well as the carpal compression test. They'll bend it over and they'll kind of put their finger in there too. Whatever, as long as you're compressing that nerve, those are the 3 major tests that we like to see. One other test that you'll kind of see sometimes as a distractor is called Finkelstein's. A very similar area, but very different presentation. That's for something called de Quervain's tenosynovitis. That's this inflammation of the synovium sheath over the thumb. That's completely different than the carpal tunnel. So if you see a test question, not in this course, but in a future one, and they're asking you special wrist test, and they throw a Finkelstein's in there, think about flexing that thumb over. I think we've seen a meme of it where, hey, do this and flex it down really hard. It's going to hurt really badly. That works for anyone. Do it very gently with people if you're doing Finkelstein's. But this is off the test, just so you guys have some background, so you're not looking at a slide going, I don't understand, and it's going to take me another semester to unpack it. All right, juniors, if you guys are paying attention, come on back with me. We're going to go over a couple of review questions again. So this one, and I put the correct answers in. I know that was a stress point for people last time. All right, so I got a 55-year-old male who presents with 4 days of progressive symmetric weakness, paresthesias that began in his feet and have ascended to his knees. 3 weeks ago, he had an upper respiratory tract infection. Exam shows decreased vibratory sense in both feet, absent patellar and Achilles tendon reflexes. Muscle tone is decreased. Plantar responses are flexor bilaterally. Is that negative or positive? What's plantar flexion? Is that the Babinski's reflex? So that's negative, right? Cool. Which of the following is the most likely diagnosis? Think which one of these conditions is kind of rapid onset. It's very common for us to see this. Starts at the feet, works its way up. Echo, we like echo? Good, me too. Why is it, I heard some alphas in there. Diabetic retinopathy, super common, but is that kind of rapid onset or is that slowly over a longer period of time? You might see a similar pattern, but that's why we pay attention to, hey, what's the one key that kind of clues me in with this upper respiratory tract infection? That causes some of the GI, so you can get it with either GI or you can get it with upper respiratory tract infections. Either or in there. It's in the slide. I don't think I bolded that exact one. I think I have bolded the Campylobacter, but just know it's not just GU. It can be related to upper respiratory tract. But that should kind of clue you in. If someone has a viral infection before, there's only a few things that cause that. That's not just I don't throw random distractors in that are immaterial to the case. I disagree with doing that. The cognitive load is too much for you guys as is. All right, if I put it in there as history, it probably belongs in the question. All right, ALS, chronic progressive over a series of years, right? Myasthenia gravis, doesn't really sound like it. We think of more people with ptosis with that one. And then ischemic stroke. Not really. We know some cerebral signs. Stroke can present with a lot of very strange things, but there's a ton of things that are really indicating me towards Guillain-Barré. Do people feel good about this question, or was it kind of way off base? A little closer to like softball to mid-range question? It might be. It might be. Guillain-Barré is going to be on the test in one way or another. All right. Next one. I got a 42-year-old woman with past medical history of myasthenia gravis. Gave you a diagnosis. And she's managed with pyridostigmine, the scary birth control. Presents with a potential bacterial infection. Don't worry about what the bacterial infection is. What class of antibiotics would be contraindicated based on her past medical history? So this is that really easy first level recognition question, but I put a patient vignette on top of it. So don't get distracted, read the question first, understand what you're looking for, and then read through that patient history. That'll get you through the pants every single time. So which one are we thinking? And we're not going to ask classes of antibiotics within that because that kind of scares us, and we just got beat up in pharmacology, I know that. Sorry, there's a couple of pharm questions today, but I understand why you guys were a little distracted yesterday. I apologize for hitting a heavy course. Okay, so this is a nice first order question, so as I'm writing more for my sophomores, I do more of these types of questions. What is the most appropriate initial treatment for Guillain-Barré? And if you know, do you guys know what the toolbox is when you're doing rock, paper, scissors? It's when you hit them with scissors 3 times in a row. It's Guillain-Barré is going to come up in the test a lot, so just think of that. All right, so what is the most appropriate initial treatment for Guillain-Barré? So do steroids work for Guillain-Barré? We had a couple of different conditions where like, yay, steroids, and we had a couple other ones that no steroids. What's that condition that presents very similar to Guillain-Barré, almost indistinguishable, but then we like steroids? CIDP, that patient that I have myself, and I'm like, I've never heard of this before, and now I have to go teach it. We learn as we go. All right, last question. So I got a 55-year-old woman with 3-month history, slowly worsening ptosis. And we know the word ptosis at this point, right? No one's like, hey, I can't actually read Roman numerals and I'm too scared to say anything. We're good on those? Okay, sweet. So we got double vision. Notes that it becomes worse during the course of the day, but resolves with rest. What's the most likely diagnosis? What's one of those conditions that gets worse towards the end of the day? Kind of a weird mix because we've been on farm for a little bit. It's okay. So the thing that we're looking for is myasthenia gravis. Think gravis, think gravity, think it's heavy, it's wearing on me throughout the day. That's the one that worsens with repeated sustained contractions. When you guys are thinking about how frequently some of these things happen, Lambert-Eaton's a lot more rare. Myasthenia gravis, I've seen 3 or 4 people in my phase 2 alone. That's going to be a lot more common for that. Not that a lot of my questions are going to be based on like gross level commonality, but occasionally you'll get these very weird ones that are like, that's a very rare genetic condition that's not going to randomly onset at 55 years old. What about that iatrogenic Botox? What's iatrogenic mean? Whoopsie toodles, we caused it. She probably got Botox off on the industry or got migraine shots for that. And as a result, it can infiltrate into other locations, and that can cause some droop. Is that going to get better with rest? No, because what's actually happening is we're permanently blocking it. When you get a Botox, you're on for the ride until that Botox wears off completely. I got one more. It's a pharmacology question. We can skip it if you guys are farmed out. Don't worry, it's atropine. You can study that one. I wrote it, and then I saw the test scores coming back, and I'm like, I shouldn't have done so many questions. I appreciate you guys. It's tough. No, I mean, you guys were emotionally going through one of the harder tests of IPAP and like hit you with a bunch of farm things afterwards. Like that's kind of toned down. So, you guys are working really hard, and we really appreciate what you guys are doing. I don't mean to roast anyone. All right.
Don't mean to, but you did.
No one can roast us but ourselves. Okay. Today we're going to cover weakness. It's a couple of different conditions. The biggest one, we're paying attention to upper and lower motor neurons, and we have a pretty good handle on that. Upper motor neuron, dinosaur arms. Lower motor neuron, flaccid squid arms. And then we're going to go through a couple of different gaits. I have a bunch of different videos on that to show you exactly what the gait looks like, and then we'll go over some descriptors in case we ask questions, because it's very hard to put a video, but being able to recognize a gait. We see people kind of walking around funny all the time. It's like, I think he's just old. In reality, there's different components of the gait that we can say, hey, this is a myopathic gait, or no, this is a hemiplegic gait. We'll show you those. There's one really good YouTube video. I'll make sure you guys have the link for it later that I pulled it all from. It's one doctor that did all the walks, and he does a really good job of it. But we'll go through those. So weakness in general, weakness is kind of like one of those weird like dizziness terms where like, hey, how do I put this in terms that's like I can't just diagnose someone with weakness. You can, but you have to kind of dig a little further into it. It could either be a muscle problem or a nerve problem. I'm not so much worried about the muscle problems today. I'm more concentrating on the nerve issues. And is it a peripheral nerve that's causing the problem? Is it a combination of the nervous system? or the central nervous system, or a mixture of both. Are we seeing upper motor neuron issues or lower motor neuron issues, or a little bit of both? And then true neurologic weakness, true weakness, is a loss of motor power. You got to differentiate this from people that are just tired versus people that aren't really trying too hard. Here you can see Palpatine. He says he's too weak and then immediately kind of looks at you afterwards. You'll do this with patients where they're like, I can't barely move, and then they get up and walk out fine. Just pay attention to like the differences. And then when we're localizing, just think of like, hey, it starts in the brain, goes down through the spinal cord, hits a peripheral nerve of some variety, goes to the neuromuscular junction, and then the muscle. We're only worried about those first four because that's what we're paying attention to. A lot of our disease states yesterday kind of fit into that pattern. As you kind of study those, pay attention and say, hey, I know all these things sound similar. Where's the issue actually happening? Is it in the nerve? Is it a peripheral nerve? Is it the neuromuscular junction? Chunk those together. All right, when we deal with weakness, there's a couple of different things. We can have what's called, I actually never have seen let me pull up my laser pointer again. Monoplegia, no one really uses it to describe that. They'll just describe it as a paresis or palsy of an upper extremity or lower extremity. But hemiplegia, paraplegia, and quadriplegia, we probably see those terms just from walking around. Hemi, think in half. When it's para, think Paralympics, bottom down, they're going to be in some type of wheelchair. Quadriplegia, obviously all four. But that's a very easy way to keep all those straight. And then I talked about it yesterday with the juniors, you guys were on the call, but we feel good about the difference between paresis and paralysis. Which one would we rather have? Paresis, because that's probably less worse. If you say paralysis and you just want to be in a wheelchair, that's a thing too. But okay, so kind of go into that H&P real quick. Sudden onset, think vascular insults. Hours to days, thinking more of infectious, inflammatory, and toxic things. If things are kind of chronic onset over a series of weeks, I think more immune mediated because those things take time to kind of work their way up and start affecting us. Months to years, I'm starting to think degenerative, all those hereditary Charcot-Marie-Tooth disease, chronic myopathies can occur with that. And then it kind of fluctuates throughout the course of the day. Think of that myasthenia gravis versus that Lambert-Eaton syndrome. If it changes depending upon how well rested I am or not, a lot of times that ends up being the neuromuscular junction. And then things can either be episodic, meaning it happens the same way every single time. I can have it and it kind of gradually gets worse, or I can have rapid fluctuations where it's sudden onset, sudden offset. Pay attention to those clues because those things will clue you into what we're dealing with. What's important when we're dealing with weakness, same thing as neuropathies, it helps to identify where exactly it's happening. If we see hemibody, meaning, hey, one complete half, I'm starting to think hemisphere because that's in the same term. That might kind of give me more of an indication it's a cerebral lesion. When I'm thinking bilateral below a certain point in my spinal cord, like this person here, this paraplegic, because they're in the Paralympics, they have a wheelchair, I'm thinking a spinal cord injury because that's where injuries of that type create that pattern of weakness and of neuropathy. If I see that distal symmetric where it's kind of coming up, I'm thinking the beatus. I'm thinking B12 deficiencies, alcohol, CMT has a little bit of effect on that. But anything that's affecting the distal nerves and working its way up, it's that length dependent, it's worse the further it is, I start thinking of those causes. And then severity is always important to pay attention to, but family history is going to get you out of a ton of holes. If I'm going to give you something genetic, I'm going to give you a family history. But then it's not just going to be, hey, he has a family history of CMT, he has these symptoms, what's the diagnosis? It's going to be related to, hey, what's the treatments for this? I'm going to give you the diagnosis and then expect from that based on the family history. But in actual patients, it's very helpful. And I think this last picture was trying to show waxing, waning course throughout the day and how it affects our neuromuscular junction there, just for our visual learners. Kind of the same thing that we talked about before if we're dealing with brain cord versus spinal cord versus a peripheral nerve versus neuromuscular junction. Just in more words if you guys wanted it spelled out differently, but this is the same content as before. Our physical exam, we're obviously looking at muscle appearance, muscle tone, strengths. You guys saw that thenar wasting we saw a second ago. Pay attention to that. A lot of times when we get older, our muscles kind of sag down a little bit. We just kind of get old because connective tissues don't work no good no more. Compare one side to the other, or if it's a facial thing, take out their driver's license and look at that. It's very easy to go back and look through history. A lot of times I say, hey, do you have any recent pictures of you on your phone? And a lot of times it's grandpa and he takes a ton of selfies when he's trying to log in. People have pictures of each other, yet you can compare just to say, hey, you actually have a ptosis when I look at this picture of you that are normal. It's a lot of times there's subtle findings and you're like, is your face always like that? And you're like, yeah, I was born with it. And you're like, okay. Now dig into the available resources you have to do that. So muscle tone, I think we've beaten this to death at this point. Dinosaur arms, squid arms. Does everyone feel good about that? I think it has some other words in here. Rigidity and tone throughout passive movement is not velocity dependent. So even though you're moving around, they're still going to be really stiff when they're doing it. Extrapyramidal versus ganglia disorder. Extrapyramidal, what is that for us again? So I got pyramidal symptoms. Those are those deliberate movement ones. My extrapyramidal ones, that's dealing with positioning, that's dealing with coordination, that's dealing with some of those more passive things. Then hypotonia implies a lower motor neuron lesion. Think floppy baby, floppy squid arms for lower motor neurons. And then hitting upper and lower one more time. I think I moved it earlier in the course, so there's still a lot of content here for that, but I'll make sure we've hammered it home enough in the lessons that there are some upper and motor neuron findings test questions, specifically, hey, which one's Babinski's positive or negative, some differentiators like that. Upper motor, lower motor is just two options. I have to have something that has more distractors, but just for how much time we spent on it. All right, let's go over our cortical spinal tracts. We only have to memorize 3 tracts to understand spinal cord injuries, correct? What's the motor neuron one for us? Cortical spinal, because it's coming from our cortical and it's going down to a spinal level. And that's our upper motor neuron. It starts here, goes all the way down. At what point does it become a lower motor neuron? Kind of at that spinal level where that anterior cell is right there, it connects up. So any injury along here is going to cause symptoms of an upper motor neuron injury, aka that spastic dinosaur arms. After that, as soon as it exits the spinal cord there, it's a new cell, it's going to cause lower motor neuron for us. And our cortical spinal tract, at what level does it cross over? Just at the medulla. Don't worry about, hey, which portion of the medulla, you'll drive yourself crazy. You know, it starts on one side, goes all the way down. I get an injury here, is it going to cause same-sided symptoms or opposite-sided symptoms? Same side. Because the injury's on the right side, the nerve keeps going down on the right side, I'm going to get that spastic paralysis on that right side. Okay, lower motor neurons, these ones as they're coming out of the spinal cord here, those are my ones that are excitatory. Those are the ones that when I have an injury to that lower motor neuron, I'm going to have floppiness to myself. And then I think this kind of covers most of it. Most of this is just background. Disturbance any function of the peripheral nervous system. Anterior horn where it originates, can go into the nerve root, the limb plexus. So do you guys know what your brachial plexus is? I know the juniors are pretty big into that. A lot of times our nerves, as they're moving out from our body, they don't just like keep branching off like our circulatory system does. Nerves can kind of join together and create what's called plexuses. We have brachial plexus is a big one for us. Different nerves go in, they combine in weird ways, different nerves go out. We're not going to test you on, hey, do you understand brachial plexus? Did you get that during A&P? A little bit, real fast. Don't worry if you see the charts and you're like, oh my gosh, what is this? I'm sorry, go ahead. It's not necessarily doing too much thinking at that point. You don't have like a little motor cortex inside your shoulder. That's more, hey, the nerves come and join in a certain way and leave in a certain way. It's more like an intersection, I guess, would be a way to think about it. And then reflex arcs is, we talked about this last time. What's this purple thing here? It's a little interneuron. When we test a reflex, does that go all the way up? No, stays level. And then hyperreflexia, upper motor neuron lesion, because again, that inhibitory lesion is not there anymore. Hyporeflexia, floppy squid arms, I'm not going to have a reflex. What's the one on the back of my heel? S1. Why? It's Thursday afternoon, we closed IPSA. I'm getting better, I've been stretching. All right, you guys can go through these slides later on if you want to. It's just kind of a demonstration of what's happening between upper and motor lower neurons. We've covered this pretty much at length. Does anyone have any questions or wants me to go through this nice and slow? All right. Cool, that's the background stuff. Appreciate you guys putting up with that. Let's go into some of our imbalances in our gait testing now. So imbalances, don't worry about this being like a huge testable point. It's more meant to demonstrate some stuff before we get into those gaits, that main one or point we wanted to talk about. When someone has imbalance and they're kind of tipping all over the place, it can localize to a lot of different spots. Where's the first one we think about when someone's kind of like has that ataxic gait and is kind of falling over a little bit? What's our posterior fossa localizers? Cerebellum, right? Because that covers coordination for us. Cerebellum is a great place to start, but there's a couple other things that can be involved with that. What's very closely tied to that, we just took, you guys got ENT, right? Yeah, that's fair game. Okay, so ears. Vestibular system, really important for us, right? That's kind of thrown off. It throws weird signals into the cerebellar system. That can cause imbalance for us too. The other place we see it is with the sensory ataxia and sensory limb ataxia. Think about your body, close my eyeballs. I should be able to touch my finger to my nose. My body has position sense for itself. What's actually happening is all those little proprioceptive devices that are like throughout my tendons and my biceps and my arm, those are subconsciously giving myself signals like where my body is at position sense. That can get knocked out, especially when we start talking about some of those spinal cord lesions. Specifically, spinal thalamic gives you a lot of different weird proprioceptive stuff, as well as dorsal columns are involved a little bit too. But when we see injuries of that, it's not just, oh, I can't feel sharp there anymore. Hey, this person might be really uncoordinated on that limb that might have otherwise fine motor control. All right, so we're gonna cover through a couple of different gaits. Here's the complete list for you guys. Don't worry, most of them, like the main ones, are going to be your hemipyritic, your parapyritic, your step bridge, your waddling. Parkinsonian's easy to spot from a day away. And some of these other ones are like secondary ones. So it's not like, oh my gosh, I have to recognize like a billion different walks. There's only like 4 or 5, and they're very easy to differentiate. We'll spend a little bit of time on them. So this first one, let me make sure this is muted. Get rid of my laser pointer.
Hemipyretic gait.
Shush.
With the other side being normal, heavy normal.
There we go. So with the hemipyritic gait, what he's doing, it's one side of our body has a little bit of paralysis going on to it. It's caused by injuries to the brainstem, because I'm thinking hemispheric localization, hemispheric gait, hemipyritic gait. So what's happening as he's walking is that leg, he's taking it out and he's adducting it around and coming back around. He's kind of scooping that leg around. That leg, it may still work a little bit, but it doesn't have that fine motor control anymore. So what he's actually doing is he's stepping out and the exact word is circumducting that leg around. Circumcising, that's a different one. You get that in GU. Don't do that. This is neurology. The words I'm thinking here is circumduct, and specifically on one leg. On that contralateral side, yeah, you're going to have a lot of different stuff. What's going on with his arm? He's got dinosaur arm, but only on one side. He's kind of protecting himself a little bit while he's walking, but we also see evidence of an upper motor neuron lesion where it has a little bit of spasticity to it. As far as like all these different descriptors, I know it's kind of very easy to get lost in, well, this is flexion, this is extension. I'm not going to ask you the position of an elbow on a hemipyritic gait. It's going to be very obvious that this circumduction, that sweeping that leg around, that description is what's going to be there. With that being said, let me hit play on this one. If we have a hemipyritic gait, it follows that we can have a dipyritic gait. That means both sides. That doesn't mean, hey, this guy's completely paralyzed. It might be more of a paresis on both sides. But neither of those muscles are really working great. Here we see that circumduction happening, and it's happening on both arms, or excuse me, both legs. He's kind of sweeping it out wide and around. The reason being, that leg is very difficult to flex up. So he's trying to compensate by moving it out of the way and moving it back around. Moving it out of the way, moving it back around. Are you guys able to see this on your iPad, the videos, if it's embedded, or does that go to crap?
No, but
It's hard to do it, or is it just really bulky on file size? PDF doesn't matter. What if it's in PowerPoint as an embedded video? I can do as a GIF as well. Does that work, or Jeff? Who says Jeff? If it's a GIF, does that work better for you guys? No? Keep doing what I'm doing? Appreciate you guys. All right, so this next one, we may have seen this before, specifically with Charcot-Marie tooth disease, where people have a lot of issues with trying to clear that leg. What's happening is they're stepping, and they kind of almost look like they're trying to do a moonwalk, where they lift the leg kind of extra high. with people with Charcot-Marie tooth disease, we see a lot of sensory issues as well as motor, but those sensory issues, I have trouble walking on grass because it feels very strange. I can't sense where my leg is. These people, the muscles work fine, so they can adduct, or they can flex and extend the legs okay, but they're stepping kind of high because they're like, hey, I don't want to trip. You ever kind of walk around at night and you're like, you don't shuffle your feet, you kind of pick them up a little bit extra so you make sure you don't step on something. Or I think they do that during Scooby-Doo where they're like trying to sneak around and be really sneaky. Think of lifting the leg kind of high to avoid stepping or tripping on something because I have a sensory issue at this point. As you see his legs, I'll move my mouse out of the way. You can see he's kind of very slowly lifting his leg, putting it back down. Look for that extra high gait. Think CMT if you see it at a gait like this one, but this is steppage or neuropathic gait. All right, waddling. Waddling is, originally I had a hard time kind of understanding this one. What's ended up happening is we're having a weakness of our proximal muscles. That's more indicative of a myopathic condition. We're not so much worried about that in neurology. It kind of looks a little bit silly. You've seen people walk like this at the end of the day where they're just kind of waddling. And what they're doing, you'll do it if you get tired enough because your body's just like, oh, my proximal muscles are tired. And you just kind of waddle. You're like, please don't give me another test. But you're kind of stepping side to side. And what you're doing is you're shifting your weight to that leg that is planted so you can move that leg. Because those proximal muscles, those ones that like to flex, those aren't quite working so good no more. I know he kind of has the swinging of the hips is an important thing. Think about planting yourself on that leg that is good, swinging your hips to that side, and just kind of, they're literally just going to waddle as they're walking. Watch for waddling. You'll see it, especially at the end of a Friday, someone will waddle. Oh, yeah. All right, you'll like this gait next a lot. This is your Parkinsonian gait. Does anyone have a family member with Parkinson's disease? So this is a very typical, what you're going to see is that tremor in the hands. That's that pill rolling that you've probably seen written before, but you're like, what are they talking about? Imagine if he had a pill bottle in his hand. He's rolling it, kind of rattling it, because we give him a ton of pills to try to correct that. Let me hit play on that again. So what we see is he's going to try to take a step, but he's having difficulty initiating that movement. Is that ataxia or apraxia? Praxia, we're having difficulty with executive function. Ataxia is more of that stumbling, waddling gait with coordination issues. You'll recognize this. You'll see this a lot in elderly folks, and like, I can spot that from a mile away. Recognize it when it's like not as obvious as our friend here is doing. It has the term turn and block. Does anyone know what that is? I always think of it like Batman when he has like the neck thing that's way too stiff and he has to move his whole shoulders to talk to you. When a person has this disease, turning to move in a very fluid way is kind of difficult. What they'll do is they'll walk, they'll stop, they'll turn, and then they'll start to walk again because a lot of that coordination is gone. And then of course we see that decreased facial expression. We talked about a couple of cerebral signs. Affect was one of them. This is where affect comes up again. And we'll talk about it in full when we deal with Parkinson's in total. All right, this next one is kind of similarly related. I don't know if the video is going to capture it super well. So this person kind of looks like a Parkinsonian gait where they have a lot of difficulty walking, but when they stop, he stops assisting him here, he's unable to keep walking. It's that difficulty with keeping things moving. Apraxic gait versus a Parkinsonian gait, very hard to differentiate the two. I'm not going to ask you a test question to ask you to split the two, but it is one of the classic gaits. If it doesn't fit the full Parkinson's, but they kind of like stop, and they have a lot of difficulty, think more apraxic with that executive function. All right, this one's going to look a little silly. If you need to laugh, that's okay. Get it out of your system now. So this is called a choreatic, aka, you know what chorea is? Like choreography? It means dancing. So people that end up having that, I knew someone's grandma that had this, and I thought I was like 8 years old or something, and I thought she was just dancing like a crazy person the whole time. She had a cane, and she was just always kind of bebopping around, and I was like, is she like a dancer from before? Like, what happened to her? It's like grandma's always dancing, doing a dance competition. And this movement, it seems kind of like ridiculous when you see it and almost kind of like exaggerated, but that is the exact way she presented. And I was like, oh, she had a choreatic gait. Like that was what was going on. So chorea means dance. When we have an issue with our basal ganglia, that bottom portion of our brain that helps kind of coordinate movement, it might not just be, hey, movement's kind of suppressed or coordination goes out. It might cause these very weird, jerky, strange motions that almost kind of seem kind of sinuous in nature. kind of a lurching appearance. These people are actually like really stable. They don't fall down. They look like they're about to, but they, for whatever reason, everything else kind of clicks into place, but it's a very strange gait to see. All right, this next one, so we went over apraxia, we got ataxia now. What do we do for drunk people? Call them ataxia. So this one, think of, okay, very difficulty kind of maintaining my balance. I'm trying to do it, he's doing it much better than I can. He's almost trying to walk a line there. We see a lot of crossing over where he's like kind of like falling to one side or another. With someone with choreo, they're gonna like kind of move a lot. With these guys, they're gonna move a lot, but they're gonna fall down a lot more than someone with a choreatic gait. It looks like a drunk person trying to walk. If you're like, hey, I think he has more of an ataxic gait, you're pretty much where you need to be. All right, sensory ataxia, it's going to look the exact same as the cerebellar ataxia. The difference is if your eyes are closed or open. Sometimes if we're able to maintain our balance with our eyes open because we're overcoming what's going on with our sensory system, that's great. But then we close our eyes and we start falling over like crazy, we've taken out our one reference because your body's able to compensate. If my vestibular system's out, I'm going to use my eyes for 80% of what I'm doing. If my eyes go out, my vestibular system's going to become stronger. If only one portion of that is out, pay attention to whether it's worse or better with eyes open or closed. Do you guys remember which one Romberg's is? I think we're combining the pronator drift, and then Romberg's is just standing there. We can do them together during physical exam, that's perfectly fine. Just be able to differentiate out the two tests. My Romberg is closing my eyes, stand there. Do I be in a place where I can catch the patient? Every single time. And then, as opposed to the opposite, if my sensory system, if I'm thinking more vestibular issue, think, hey, my vestibular system on one side of my body's off. That's going to cause my head to kind of go to that side. What can end up happening is we can have a very one-sided ataxia where it's not just, oh, I'm kind of falling over each side. I always fall over to the left. Think of that localizing to the vestibular system on that side. Does our vestibular system cross over? No, it'd be crazy. It's going right into the brain right where it is. Don't worry about, I know, desiccations and other weird things. Not everything's completely crossed over all the time. All right, this next gait, it's a psychogenic gait disorder, meaning there's nothing organically going on neurologically with him. I'll hit play just to not force it any further. Does this look like any of the other gaits we were doing? He's just kind of kicking his legs around. He's just kind of walking, and he's kind of actually bouncing with his upper half of his body. So we like see a little bit of circumduction, so not like a cleanly hemiparetic gait or diparetic gait. He's bouncing up and down, but it's not that kind of choreoform dancing kind of sinuous maneuvers. He's just kind of bouncing himself. Is he doing that on purpose? Maybe, maybe not. We start thinking conversion disorder. This isn't like a total, this is more of a finding than a diagnosis. I'm not going to say, oh, you have aphasia, aphasia. Hey, we have a finding of this very specific gait. I think there might be an underlying psychological condition. Go see Captain Lane and figure that out, please. The word's kind of weird. It's actually Greek. Most of our stuff is Latin. It means can't stand, can't walk. Because for whatever reason, as soon as he sits down, I paused the video too soon, he sits there perfectly fine and normal. There's no other movement stuff. It's only when we stand these things are exacerbated, and when we try to walk, it may look like someone that's just kind of doing the can-can off to the side. It may have combinations of different gaits. These people aren't studying the gaits online and saying, oh, I should walk with a hemiparetic gait today. They're just moving around because that's what their brain tells them, hey, this is what presents as, either consciously or subconsciously. Conversion disorder, we haven't covered psych. We have covered psych. We feel good about conversion disorder, so that's a good link to make. Sweet. Check. All right, that is it for the gaits. Do you guys want me to post that as just a YouTube link? Would that be helpful for watching that? There's one video that does them all. That's sweet. I'll put that in that bonus add-in at the end. Yep. That's why some of the what's are yellow. Sorry, Manny. Manny's slides are yellow. I don't know why. Gasp. If I'm doing something that makes the slides look weird, just let me know so I can fix it so you can get clean. All right, multiple sclerosis. Do you guys ever get the red arrows on like the exams when you get the blue boxes? And some instructors do it where they put the exact lines so you don't have to scan through it to read it. I love doing the red arrows. Do you not do the red arrows on the blue boxes? Sometimes? You know when you get a question wrong and the box pops up and says, here's the slide. Unless you've never gotten anything wrong, you have all hundreds and you never looked. There's one of us among us. When you see those blue boxes, I like doing the red arrows that says, here's the exact line that's discussed as. If you see a red arrow in the review, it'd be like, oh shit, I'm not supposed to see that. I'm going to go back, pardon my French. I said a naughty word. If you see that, I'm going to throw it out anyway. There's no other like weird, put a period in there. This is italicized, that means it in there. No, that's not a clue of, that's the secret code. You'll drive yourself crazy trying to unlock that. All right. We're going to talk about 2 demyelinating diseases real quick. And you say, but Major McMahon, we already covered demyelinating things yesterday. The things that we talked about yesterday were more peripheral things. It starts at the bottom, works its way up because they're length dependent. They're working on peripheral nerves. When I think of Guillain-Barré, is my Babinski's positive or negative? It's a lower motor neuron being affected. It's going to be negative. So these things that we're talking about now, these demyelinations are happening centrally. Think upper motor neuron. That's why they're chunked together, they're kind of separate. I know it's kind of a continuation from yesterday. So this first condition is called MS. Does anyone have a family member affected by MS? I see a lot more hands than I did yesterday, even from Guillain-Barré. This is a very, very common condition to see in clinic. And when I finished up with neurology, I honestly had a difficult time saying, yeah, I know what MS looks like. I was like, is that kind of like cystic fibrosis? Is that kind of like Guillain-Barré's? I don't know, it's just neurologic. I didn't know what the common presenting symptoms were. If you don't get anything else from this course, just pay attention to what a presenting patient with MS looks like, because you will come across these in clinic. A lot of times that initial presenting symptom isn't like, ha, gotcha, MS. It's a weird like, oh, that's weird that kind of happened. There's a couple of things that are very pathognomonic for it, meaning if I hear these words, it should be an exact diagnosis. Pay attention to this, you need this for clinical practice. I'm going to hit you with the toolbox, aka scissor, scissor, scissor. If we're playing rock, paper, scissors, there's going to be multiple questions on MS. All right. You're going to try the toolbox on someone now, aren't you? Hell yeah. It throws them off every time. You know what 3 rocks are? We'll go over that after class. Rock slide. All right. MS is an immune-mediated demyelinating disease of the central nervous system. So now we're thinking upper motor neurons. It's characterized by inflammation, demyelination, giliosis, and neuronal loss. Does anyone know what the giliosis or giliosis means? Giliosis. I'll show you a picture in a second, but we're kind of forming these actual physical plaques in our brain. I'm sorry? Okay. We're actually forming physical plaques in our brain, and we can see evidence of that when we shoot MRIs. And here you can see some of these. So let me pull up my laser pointer again. Pew. Here we can see some of these plaques developing around the brain, and we'll talk a little bit more about that. By people that I'm thinking about, 3 times more likely that it's women. It may be between the ages of 20 and 40 is my average diagnosis. So I don't think 8-year-old kid, think kind of more like the age that you'll be seeing in clinic as active duty providers if you're active duty. And then much more common about European lineage for some reason. So some of the risk factors, I just like this image because images are way better than just text. It has a genetic predisposition. It's not a 1-for-1. It's like, hey, if you have a family member with MS, you're going to get it. You don't have to test people because they have a family member with MS, but just pay attention to those symptoms. And if they present with the initial symptoms and they have a family history, hey, that's a lot stronger case for that. Prior Epstein-Barr virus. What does Epstein-Barr virus cause in us? Mono. So if you have mono after childhood, that's an indicator for us. Cigarette smoking can predispose us. Vitamin D. I think they list a couple of occupational things. For some reason, it's like people that work out a lot, people that smoke a lot in military service. I'm like, that's just us. But a lot of risk factors are associated there. You'll see all sorts of weird ones, like people in cell phone factories end up having a lot higher diagnosis and they can't pin down the chemical, but they'll see like kind of cropping ups of like, hey, these very specific people can end up with it. Don't drive yourself crazy trying to find them all. So let me pull this out. Boop. The thing that is kind of pathognomonic for MS that should clue you in, your number one, we're going to go through a ton of initial presenting diagnoses. If you see painful optic neuritis, what that is an inflammation of the optic nerve as it's going out to an eyeball. Monocular vision loss, you got to think MS for anything else. There's a couple other things that can cause painful vision loss. MS should be number 1 on your list. Partial transverse myelitis. So we see some spinal cord symptoms, but it's not the entire cross-section of the cord or functionally lost. So we're gonna go through like different spinal cord issues. They're not gonna fit that clean picture. It's gonna be kind of like a spot here, a spot there, kind of weird findings throughout. The last MS patient that I had was just a weird combination of like back pain, some cranial nerve findings, and this leg stopped feeling great. It was very weird and over a longer period of time that these things developed. It's not gonna fit one of those typical patterns. I think if you had to kind of file it into it, it's gonna kind of present as that mononeuropathy multiplex, a lot of different discontinuous spots. You'd be like, man, this neuropathy doesn't fit a radiculopathy or any of these other typical ones I've seen. He has some eye complaints, think MS. We can have some brainstem syndrome, so that can cause a lot of cranial nerve findings. My guy ended up having loss of taste in his tongue. And then we can have some long track findings, meaning going all the way down, it's gonna cause some upper motor neuron issues. And then we have something here called internuclear ophthalmoplegia, ONI. It's an impaired ipsilateral abduction with adducting nystagmus of the contralateral eye, which is fantastic. I just put it in a video to show it to you. So as we're swinging the flashlight back and forth on this guy, notice how his eye, especially on this side, kind of lags behind the other one as it's going across. As he crosses midline, it kind of hangs out for a second, and then he crosses over. That eye, when it's going back over, it takes a second to get back. It's almost like his eye's on a delay. When my eye lags going out, which cranial nerve is that? 6. When my eyeball's down and out, which one is that? 3. What's 4? Stack in my head, because it's kind of high compared to the other one. Which cranial nerve's ONI then? It's internuclear, meaning it's a combination of the two. And I'll show you in a second. Remember that picture I showed you that was like inside the ponds and it was like a bunch of crazy things? And I said, if you value your sanity, you don't look at it. I'm sorry for your sanity, we're gonna look at it. There's actually a connecting pathway between the two cranial nerves. And when that gets affected, this is very specific for that. So think instead of abduction, or adduction is affected now. That eyeball, the very extreme cases, you'll see it stuck as you keep going. One eye will still be looking at you. We'll go over ONI. It's kind of a weird finding that I didn't really know before teaching this course, and I'm like, oh, this is actually super common. I was supposed to know this. All right. This has kind of a very long list of different, don't memorize percentages. You'll drive yourself crazy trying to do that. Optic neuritis, very common initial presenting symptom. A lot of other things can present over a long period of time. Optic neuritis will actually drive you in. I see sensory loss being a very common one too. I think those weird paresthesias hit different points, doesn't really fit a typical pattern, might be because of those lesions all throughout the central nervous system. I see paresthesias, diplopia, because again, that own eye is being affected, that eye might see double vision. A lot of times patients won't come in and say, hey, my eyeball's stuck. They're gonna notice it very subtly with that diplopia. Ataxia, vertigo, bladder symptoms. I think these are all pretty easy for you to read. Falling is a very low percentage of them. And then I just wanted to highlight for you guys that internuclear ophthalmoplegia. I'm getting better at pronouncing things every day. So what's happening is this little, don't worry about remembering the name of this pathway. I think it is the longitudinal fasciculus, the medial one. Just know that 2 of these cranial nerve centers, I got 3 and I got my abducens 6. Those aren't talking to each other anymore, so the eye's no longer coordinated. So I can get that weird, the eyeball gets stuck and then it kind of tracks over. And then, does everyone remember Marcus Gunn pupil? Brought a gun to a knife fight, got punched in the head, now we do the swinging flashlight, doesn't add up too good. All right, I got a couple of signs here. I want you to pay attention to these 2 in particular here. If you're gonna highlight them, now's the time. I have this thing called Uthofsen phenomenon. Basically that's saying, hey, as these people get exposed to heat or they try to exercise, their symptoms are gonna get way worse, especially fatigue. And then I got Lahermit's sign. That's when I flex my neck forward, and that's gonna cause this electric-like shock going down my spine. You can flex their neck forward, or you can just have them do it on their own. I was actually going through a Reddit thread on initial presenting symptoms of MS related to this class, and a ton of people were saying Lahermit's sign was their initial presenting. I don't know why they knew the name of that as patients, but a lot of people were saying, hey, that was my first symptom that I had. My upper motor neuron type, so what does that present as? Dinosaur arms, positive Babinski's, because it's affecting the central nervous system for us. And we can get some facial weakness. I saw this with my patient. He had some facial weakness, but it wasn't a ton. The weird thing was like the anterior portion of his tongue was numb. Originally it came with back pain and we were dealing with the back pain picture. And then he told the physical therapist, yeah, the anterior 2/3 of my tongue is numb and I can't taste anything, which This one says it's not associated with it. He presented with it. Take that for what it's worth. You may get some weird presentations, but if you get weird combinations of, hey, I got back pain, flexion in the anterior portion of my tongue, and I get all these different weird kind of bulbar findings, meaning my pons, my medulla, all those cranial nerves, think MS. And then spasticity, like we talked about, upper motor neuron, you guys got it. All right, let's talk about some of the clinical manifestations. I can get sensory symptoms and I can get motor dysfunction. That can come us as paresthesias or hyperthesias. I might have to check that for you. That might be a typo, dead sensations. I think too much, too sensitive. I'll double check that for you guys. Don't lump this into a polyneuropathy, a mono or a monomultiplex. Like I said, it kind of might present as any of those because it might come in any sort of weird variety. So don't say, hey, MS is always a monomultiplex every single time. It doesn't fit a typical pattern. Ataxia can be common, especially with the cerebellums involved, because we can get lesions there as well. And then the bowel bladder dysfunction is also common. And then people have like a ton of depression and a lot of fatigue associated with it. The key point I want to point here, because this will help differentiate from the next condition we're going to talk about, depression and mood disorders aren't the same thing as cognitive abnormalities. When I'm talking about cognitive abnormalities, I'm talking about altered mental status. I'm talking about, hey, this person isn't scoring well on their MOCA exams. If someone's depressed, they're going to still come across as pretty clear and coherent. I'm not going to expect they're delirious or demented. That's important for us because is this affecting our mentation at all? No, we're not going to present with altered mental statuses with MS. That's going to be a different diagnosis if we see someone that's obtunded or is having difficulty with that. Because it's not going to be an encephalitis type picture. I'm not expecting the upper cortex to be involved in that way. But fatigue is super common among these people, 90% of people. They say, hey, it's feeling like you're trying to move your limbs through sand, grogginess when you first just start your day, my head feels heavy, like my reactions are in slow motion, making a cup of coffee feels utterly draining. You're gonna see a lot of people present with fatigue. Don't jump to MS every single time, but if you have that really constant, like, hey, there's fatigue, and then there's disabling fatigue. Pay attention to that disabling fatigue. All right, we have 3 different courses. This is a very good slide to pay attention to. I will ask a test question on it. I'm being very deliberate now. All right, so I got a couple of different varieties. I got this relapsing remitting. I think we kind of introduced that term a while ago. Here's where it's actually used with MS. Most people kind of fit into this one initially. What that means is, hey, they relapse into it and then it remits, it goes away, and then I do fine. I may have another episode, comes back. I may have another episode, but it doesn't go back down to baseline. I still have some residual deficits, even though most of the stuff kind of cleared out. And I can progress over time. And then I can get this one that's kind of the combination of that and primary progressive, where I start off with my relapsing remitting, and then I kind of start on this steady increase over time where I never really get back to baseline. Those neurologic deficits that I develop stay there in place. And then I can get primary progressive, which is just kind of a constant. I might plateau for a little bit, but it never dropped down to completely normal. All right. When we're trying to diagnose MS, don't go too crazy into memorizing this, just kind of recognize the signs and the treatments, the exact diagnostic criteria. Am I going to have someone leave my office after 15 minutes of talking with them, listening to heart and lungs and saying you have a life-altering diagnosis of MS? No, I may suggest, hey, these are symptoms concerning for it, we're going to see neurology. There's a lot of different things we need to put together in order to say, hey, this is an MS diagnosis. Even if you get the brain MRI and you see a ton of lesions and you're like, oh, that's MS all day. They have very specific things they need to look at. It needs to be lesions over time. They need dissemination in space. It can't just be a single demyelinating event because that may go away and never pop up again. It needs to be chronic over time. Sometimes that can be supported on our MRI, a single one where we say, hey, this looks like a new lesion, this looks like an older one, I think this is developing over time. And then, did you guys go over oligoclonal bands at all? Do we know what this is in like physical space? I see a lot of like icky faces, don't worry. So Clin Lab, when we deal with gel phoresis, we put it in gel. Bigger things are up here, smaller things are down there. When we actually look at people's cerebrospinal fluid, we'll see these bandings. This is a positive one right here where we see this band. You're not going to be asked to say, hey, is there banding that's appropriate here? No, they're not going to show those pictures. Where this is going to pop up, especially in like pants type stuff, they love asking about oligoclonal bands. If you see oligoclonal bands being there, being present, that should clue you into MS. And this is compared to cerebral spinal fluid. Do we normally have a lot of antibodies going on in our cerebral spinal fluid? It's pretty barren. It's pretty sterile at that point. So when we have a big pileup of all those antibodies that's causing demyelination, that's why that banding is there. So just be enough to recognize the word. That'll be on future tests with the pants. They love asking questions about illegal clonal banding. All right, I like this picture because you can see an actual, like, what an MS lesion looks like. It kind of looks like someone bruised a banana. It's kind of like this hardened portion that's indurated a little bit. It's not quite working good as the other ones. It's in the white matter because, again, this is a demyelinating issue. It's affecting the conduction along that axon. And then here we see this MRI. You can see a lot of lesions kind of pop up. And depending upon, hey, this one looks like a new one, this one looks like an old one, you guys don't need to know that. You just need to know, hey, I need to go get an MRI with T1, T2, all the appropriate ones. Do you guys know the difference between T1, T2? Me neither, it's okay. You get all of them together when you typically get MRI with and without contrast. They'll go through some of the views. Being able to converse with that with someone, they'll say, hey, T2 flare, just be like, oh, that kind of shows up with this. Don't go crazy and be like, oh, I know T1, T2, and all these different protocols. Don't memorize this. McDonald's criteria. If you're looking for how to diagnose things, just be like, oh, I think this guy has MS. You're going to go see a neurologist. They're going to put you through this criteria. It's called McDonald's criteria. That's the most current one. And there's an update as of 2024. The reason why I don't want you to memorize it, don't memorize this. Juniors, if you're awake, please don't memorize this either. As you can see, this goes on for a typical patient. Then they have one for a pediatric patient. And then they have one for suspected elderly patient. It just goes on and on and on. It's a really long diagnostic criteria. So jumping to MS is not a clinical diagnosis. Do you guys know what clinical diagnosis means? I see them, I smell it. You got strep throat. It smells like strep throat. That's gross. All right, you guys ready to take a 10-minute break? Yeah.
Oh, that's far, dude. That threw me hard for a second.
All right, you guys ready to get started again? A little bit better on the volume? I got the microphone as close as it's going to get without doing the influencer.
Is that loud enough? What?
All right, so as far as illegal clonal banding is concerned, don't worry about what it looks like. Just be able to recognize that term and say, hey, I think we're testing for MS. All right. The way we treat MS, we got 3 different categories of treatment that we like to do. It's not just, here's the next best one. Think, hey, am I treating an acute attack? Am I doing something that's a DMARD? Do we know the term DMARD yet? Okay, that was a nerve as well. All right, so it's a disease-modifying agent. It's not just a class of medication. It's kind of like, hey, what's the action I'm trying to do? A lot of those tend to be biologics. Those things end in UMAB. They do something weird with our immune system. It doesn't really matter. Not all DMARDs are biologics or immunomodulators. DMARDs are something that I'm trying to alter the course of a disease over a long period of time. That's why it's kind of this very nebulous, like DMARDs, covers everything. All right, and then lastly, we deal with symptomatic therapy. So when we got an acute flare-up, we like to do steroids about it. Methylprednisone IV if we're having really bad, especially with that optic neuritis. Don't send people out outpatient that has monocular vision loss on just oral prednisones. But we can do oral prednisone as well. And what do we have to do anytime we put someone on prednisone? Taper them back off, right? Have you guys gotten exposed to steroids yet? I flexed my bicep for the people in the other room. But making sure we're doing that. What happens if we don't taper people off steroids? They're going to get a flare-up on the bad stuff. Yeah, they're going to get a flare-up of whatever you were suppressing before. So we gradually do it. Why does that happen? I like it because we're suppressing our own endogenous production of it. And then when we drop ourselves back on it when it's not producing anything, you're going to get those same symptoms again. All right. High-dose steroids are going to shorten the relapse duration, but long-term, they're not affecting our MS disease. We can't just keep someone on that long-term and expect to change what we're doing. If we get severe refractory and this is not working, we can do a therapeutic plasma exchange. So what we're doing is we're swapping out all those antibodies with a more clean supply of plasma for ourselves. And we kind of spent some time going over plasmapheresis last time, correct? Does everyone feel good about that term? Not like, hey, how to do it, but at least, hey, antibodies are causing a problem. I want to get rid of antibodies. All right, some long-term treatments for us. We have a couple of DMARDs. I'm not going to ask you questions because we're a little gun-shy with pharmacology right now. Some long-term immunomodulators include beta interferon, atovinox. Don't worry about memorizing some of these names. Just know that, hey, they should be on some type of biologic or DMARD. And then we can do galemantir, Copaxone is another very common one. A lot of these end up being injectables. I think the first one's oral. No, that's IM as well. A lot of these are injectables because biologics get broken down a lot of times when we digest things. That's why a lot of these are injectables. Just make sure you coach your patients through it. If you put someone on an injectable medication, have them come into your clinic for the first time, one, to see if they have a reaction to it, but two, also like teach them how to inject themselves. Too many times you're just like, hey, good luck, stab yourself in the stomach, and people shy away from that. There's a couple of different ones. I'm not going to ask you the very specific for primary progressive versus secondary versus tertiary. I just want you to be able to recognize those patterns. Don't say, oh no, this is the only one that really works for that. But just know that different DMARDs work for different patterns. And then secondary progressive, that's that one that was, I'll show you the picture one more time. That secondary progressive where we start off kind of janky and then we start on that progressive where it never really gets better. I was talking with someone on the break. This isn't going back down. I don't return to baseline in that progressive phase. This is kind of straight. Maybe I plateau for a little bit, but I never really get back to normal. That one that is kind of the mixed picture where I start off good going back to baseline, but then I get progressive, that doesn't have a lot of evidence for good treatments for now. That's kind of the worst of the three. All right, prognosis. Someone was asking questions of like how many of these people end up in wheelchairs. That's a big concern for a lot of people because mobility is a big thing and quality of life thing. After about 15 years of onset, only about 20% of people will have no functional limitation, meaning only about 20% of people stay in that relapsing, remitting, always get back to baseline, high-functioning people. About half of those people will have require some type of assistance with ambulation. After about 20 years, 80% of patients will require assistance with ambulation. So over a long period of time, eventually people will start having ambulatory issues for the vast majority of people. It's favorable prognosis when we have optic neuritis or sensory symptoms at onset. And then if we have less than 2 relapses in the first year, and then minimal impairment after 5 years. Those are all very good things that are prognostic for us. Not everyone's gonna have like a ton of episodes in a year. They may go very long periods of time before they have a repeat episode. Or they may have their initial episode years ago and never sought care. And you just may be partway in through. Don't assume that the first time you see someone is the first time they experienced it. Ask those questions of, hey, have you had these things before? Because you might be several episodes in at this point. Patients with the MRI, don't worry about like picking out how many lesions, T1, T2 flare. Just know we're getting MRI with contrast because that's going to show us the lesions we want to see. Is CT going to show us this level of detail? No, it's very good at showing gross structures, but once you start dealing with the fine tissue level stuff, it doesn't show up as great. I got a question, and I'll repeat for the other class. I'll have to get back to you on that. I don't want to make up an answer. I think it's trying to say, hey, we've identified it sooner, as in that initial presenting symptom is optic neuritis. Yeah, it isn't as common as you think. I think I was talking with someone that said that wasn't a thing that their grandfather had. Not to relieve too much family history. They never had it. It's super common. It's super common as an initial presenting symptom. If my eyeball goes out, I'm probably going to the ER, right? I'd hope you would, geez. But a lot of these other things like, hey, my forearm's kind of tingly today, I'm gonna ignore that for a very long period of time. My vision suddenly goes out and it's painful, I'm going to the ER. That's why it's, even though it's not more common as a symptom, it's the initial presenting symptom that we see more often. Those things that are definite, hey, these things are big high hitters, that's gonna be way more likely that we diagnosed it early, I think is the best way to put that. All right, MRI, go get it. All right, that completes it for MS. Does anyone have any other questions? That's a very high yield thing. If you get questions later on MS, or you're like, hey, I have my own case, I love talking those because it helps like solidify it in your brain. We'll move on if everyone is good. All right, so I got this version of kind of MS adjacent. It's a demyelinating condition of the central nervous system again. It's called acute disseminated encephalomyelitis. The biggest thing here is we're seeing them now with behavioral changes, cognitive abnormalities, encephalopathy. Do we have a lot of mental status changes with MS? We may have some mood issues, we may have some fatigue, but we may even have some slowdown. But are we seeing altered mental status? No. This is very specific for this. This one, it kind of sounds a little bit like Guillain-Barré in that often it's post-illness infection vaccination. Very hard to distinguish from MS initially, but you got to look for these initial clues. The one thing that will drive you every single time, because those presenting symptoms may be that weird pattern of I don't know what's going on. If someone presents with encephalopathy, altered mental status, don't think MS. Think the acute disseminated encephalomyelitis. And I have a little chart here that kind of differentiates it out for you. ADEM, I'm thinking more children, typically 8 to 4-year-olds. More affects more males than anything else. And this is going to be a single episode, kind of like how Guillain-Barré turns into CIDP if we have more than one episode. With this, if we have acute disseminated encephalomyelitis, we're not going to have repeat episodes of it. It's a one and done type thing. And then MS is more adults, 20 to 40-year-olds, average age of diagnosis, more women than men, and it's going to require multiple episodes in order to present with that. So think younger child patient, post-infectious encephalopathy, monophasic, ADEM. And then MS is that relapsing CNS deficit separated in time and space. Have you guys seen these where I put them in the slide at the bottom where it's just like the differentiator and it looks like an equation? I put that in a few of them already where I'm like, hey, what's the big things I need to do that pull these out from other ones? Pay attention to those on the slide. I put them in there for a reason because it's going to help you differentiate when you're like, it just sounds like everything else. All right, CSF does not show the illegal clonal banding. I'm not going to write you a weird question on that. And then we'd like to put these guys on high-dose steroids, shortens the course and lessens the severity. And then here's a lovely chart kind of differentiating out the two. Again, MS, 20s to 40s, illegal clonal banding, fantastic. Might have relapsing, remitting, disseminated over time and space. Let me know if you guys see anything in here that's like, hey, we didn't talk about or that, or it's weird. Just grab me later on because I made these charts kind of fast. And then the acute disseminated encephalomyelitis, I'm thinking encephalopathy in this one. I'm thinking 5 to 8 years old, post-infection, post-vaccination. It's very acute when it happens, and it only happens once. All right, let's go into some motor neuron diseases. And you're like, we already covered musculoskeletal junctions. No, these ones kind of cover the central portion as well. ALS, does anyone know the name for that one as well? Lou Gehrig's disease, I think we just have a very good conscious awareness because we see very like high profile people, Stephen Hawking, others. Does anyone have a family member affected by? Okay. And then poliomyelitis is, I'm sorry I keep asking family members. If you don't want to vote yes for that, I think it helps to say, hey, look at the class and we see a lot of people that have had MS or like recognize people with. That's the only reason I'm asking. If it makes you uncomfortable, just get with me after and I'll stop doing it. All right, poliomyelitis. Is that still a thing? Yeah, not really, maybe. Maybe on the comeback. I got an article for you guys. You don't have to read it. All right, Lou Gehrig's disease, aka ALS. With this one, kind of the pathognomonic thing, yes, it's very progressive. It affects both upper and lower motor neurons. So we're going to see that weird combination of some of it's very spastic and some of it's very flaccid. You look at Stephen Hawking's, he's kind of slumped over in the chair. Very few things are moving. But we also have some of that dinosaur arm kind of posturing going on. If you're into the word origin, I always had a hard time figuring out what was sclerosed, and then it said the fibers in the lateral columns resulting in fibular giliosis, and I'm even more confused. Don't worry about identifying it, just know that my motor neurons are having a little bit of that hardening going on as a result. The thing to pay attention to is this is one of the most common progressive motor neuron diseases, and you're like, everything's the most common neuron disease. The exact mechanism is unknown. It's thought to be a combination of genetics and environmental factors. Not a one-for-one, like, hey, your mom had ALS, you're going to have ALS. All right, upper motor neuron findings, lower motor neuron findings. The hallmark of it, both of them at the same time, because very few things cause spastic, and squid arm. Bulbar involvement. When we say bulbar, what does that mean? Bottom part of the brain, where that brainstem is, because that's going to be all those cranial nerves. So you see the word bulbar, think cranial nerves. That's going to result in dysarthria. What's dysarthria? That's me trying to pronounce hard words up here when I'm talking to you guys over a long period of time. It's difficulty actually getting something out. It's not so much an aphasia. I can actually process the language and know what I want to say. It's just hard to say it because my mouth is tired from talking for 2 hours for the first time. And then I can have dysphagia. Does anyone know what dysphagia is? Is that difficulty swallowing? That's an important one, especially for these guys as they kind of progress in their disease. If we have difficulty swallowing, is that a big deal as a patient? A huge choking hazard, huge aspiration hazard. If we can't protect our throat, that's a problem. What's a study we can do potentially? Do you guys know barium swallow study? Has anyone ever seen it done? They give you this like nasty paste, and they'll say, bring in a couple of foods, we'll put it on your bagel for you, and then they watch you try to swallow it in live, and it's like the nastiest tasting thing you've ever seen. But that's important for them to say, hey, do we actually have a paresis going on with the muscles involved in swallowing? And then aspiration risk is another huge one for us. All right. Don't memorize this one, but know that every single thing has a diagnostic criteria, excretorial diagnosis. Just say, oh wait, there is a diagnostic criteria. I can look up that name real quick and Google search it. But again, like I was talking about where I try to like highlight the things in an equation type format. If I see progressive weakness with fasciculations, which is lower motor neuron, hyperreflexia, upper motor neuron, and normal sensation, I think ALS. Is it possible that I could have a positive Babinski's on one side and a negative Babinski's on the other? 100%. That sounds like a great test question to throw at someone. All right, ALS. Median survival is about 3 to 5 years. Typically, people are dying from respiratory paralysis. It actually had a higher incident rate than I really thought. I think people end up losing a lot of mobility very early on and very fast. So we don't see a lot of people out in public with it. Males are affected more often than females. It's a sporadic disorder. It's a dominant trait in only about 10% of cases, so it's not always a one-for-one. If you do have a family history of it, pay attention to it, though. There's no like early testing because someone has a family member with it. I think someone asked me a question on the break if like family testing for MS. There's certain conditions like BRCA gene or FAP, but not the one that we're teaching, the one that affects the colon. Those are ones that are one for one. Hey, if a family member has this, you should go get tested as well. A lot of times the family members are told this when they're tested with a very specific gene. You don't have to memorize all of them, but BRCA gene's one of them. There aren't a lot of conditions that are, hey, family member has it, you have to 100% get tested. A lot of times they recognize that. All right, early stages, we see muscle weakness, twitching. Middle stages, we start seeing a lot of difficulty walking. And then later stages, think Stephen Hawking chair. I think this was taken from Sketchy Farm over here, but treatments, there's no actual cure, but we can affect the course of the disease. The way we think of this one is Stephen Hawking in a wheelchair. Is that a real Uzi? He's taking real Uzi. Do you guys know, have you covered Latuda yet? Have you heard Latuda for her attituda or his attituda? It's an antipsychotic medication. My sister-in-law gave that one to me. And don't tell the patient that. They don't like that. Is anyone on Latuda? Don't answer that. All right. Sorry. That was not nice to people on antipsychotic medications. All right. And then we have Radiclava can also give us a little bit of relief as well. Don't worry about memorizing these ones. I just thought this was a funny picture and an easy way to memorize names. Does anyone here do Sketchy Farm? Kind of a weird mix. Are those helpful for you? Do you want more of those if I find them? We don't cover, you don't want me to cover drugs anymore.
It's pretty polar. I think it's like one side works very well for them, and then people who doesn't report it, it's like
It's kind of weird. I didn't use it originally, and I saw it, and I was like, wow, I wish I had that. All right. Does everyone feel good about ALS real quick? Think Stephen Hawking, think pretty progressive. Think upper motor neuron plus lower motor neuron. Mixed Babinski's, maybe. All right, poliomyelitis. We talk about this disease, last endogenous case was back in the 80s because we went pretty hard into the vaccination realm. We're starting to see a resurgence of it now. I think 2022 was the first case after 3 decades of complete eradication that we saw a return. Most of us are vaccinated, correct? Do vaccines work 100% every single time? We rely on herd immunity. A lot of vaccines get us close. They're like 95% protected from these things, but there's still a 5%. When do we get vaccines? every time the military brings us in. But we get a lot of them as kids, and then we grow out of it, and we stop. You have less and less. I have one friend, it's my wife. We have less and less social interaction. We're less in primary school. Don't tell her I said that. As we grow up, there's a wearing off of this, because everyone needs to get retested for Hep A, Hep B when they join the military. A lot of people get reshot because those vaccines don't work over a longer period of time. Is there a chance, if there was a huge resurgence, that some of us could potentially get infected by that? We start thinking of certain populations where that herd immunity isn't there anymore. And this is just me going on diatribe. This is not textable. There's specific parts in Texas where like no one is vaccinated, and it's very small towns, and that's where you'll see these outbreaks. The CDC watches these very closely and says, hey, this is spreading across. These isolated communities initially now have enough of it there that herd immunity is not in effect. It can start affecting groups of people even though they're vaccinated. So with polio, we see the anterior horn. That's where that upper motor neuron joins into the lower motor neuron. What's affected is that lower motor neuron. So we see that flaccid paralysis, we see that hyporeflexia, we see negative Babinski's. It's entirely a lower motor neuron lesion. We see asymmetric flaccid weakness, because it's only affecting, and here you can actually see the damage done to that anterior horn of someone's spine. I assume they removed it, so they're probably not doing too good anymore. But it causes that asymmetric flaccid weakness, that hyporeflexia, and muscle atrophy with preserved sensation. Does anyone not know what an iron lung is? It might be something that's exited the consciousness. I think I showed a picture of it a second ago. So what happened to this person? Got polio, obviously, but they're having difficulty with respirations now, right? So they're reliant on this. What's happening is they're changing the ambient pressure inside that tube, and it's allowing him to breathe. Can he exist outside of that tube? Briefly, yeah, because the muscles will still work a little bit. It's not like, oh, he's going to go without oxygen. There was, I think there's some videos of a lawyer that ended up having a successful career as a lawyer, and he's inside the tube. He can leave for maybe 30 minutes at a time, but eventually those muscles of respiration aren't quite innervated correctly. It's very taxing for him to do that. So he'll get back in the tube to sleep or exist for longer periods of time. He can't walk. He's not very mobile once he's outside of the tube, but yeah, it's not like as soon as the tube breaks. This ended up being a huge issue for him because he's like the last person in an iron lung. And they're like, we don't make the replacement parts for this anymore. And he goes, well, I need this to breathe. Let's keep going. Polio. If you guys are trying to differentiate between polio versus ALS, here's that nice comparison chart. Do you guys like these comparison charts? Are they helpful or are they overkill? Good, we'll keep doing them. Hell yeah. Do you guys know what chunking is? It's where you take things that are very similar, you put them together and say, this is close enough and I can think through that. Keep doing that, it's a good testing technique. All right, polio virus, think unvaccinated, think child. A lot of times you're gonna see this being someone that had it from a long time ago. Members of Congress will still have a lower limb that's affected by it, and that's one of the main reasons why we still have people that are like pushing for vaccination in Congress versus not. I won't get too into the political realm, but you'll see a lot of people of that generation that are affected by it, and it's one of the big reasons, one of the big pushbacks against anti-vaccination. All right, we're gonna talk through some core disorders real quick. This is what we're kind of leading up to, where we said we need to know 3 tracks. We need to pay attention to what level it is. You guys can know it by either the name, or you can know it by paying attention to where the track goes and doing the logic on that. Either way works perfectly fine. All right, so we're going to talk about some core disorders. Usually results from some type of severe trauma. Think penetrating trauma, think compression, think, hey, this person has a tumor that's compressing the spine. And it's spinal cord lesions should be suspected in people with bilateral motor findings, the sensory level, or bowel or bladder dysfunction. Those tend to go out pretty quickly. Much like how we had hemispheric signs or cerebral signs, I have my posterior fossa localizers. These are my ones for spinal cord injuries here. All right, so I think we'll step through this. If I get my posterior column that's cut or injured, it's not necessarily a scalpel that's doing this, but what's happening is that vibration, that proprioception, that fine discriminatory touch, that's going in on that same side, it's going up. If I cut that lesion, that's going to cause decrease in sensation on that side. So if I have L1 right here on my spine, everything beyond L1 is going to lose fine sensation, fine touch on that same side. The right side is going to cause right leg loss of sensation. Cool. Everyone cool with that? I'll go a little bit slower in the next ones. I just forgot exactly how they progress. So let's say, don't worry about the right fasciculate cuneatus versus your gracilis. For the people that, do you guys remember those terms from anatomy, or is that foreign? I'll throw them in there. I'm not going to ask you I'm just going to ask posterior column. So your posterior column has the cuneatus, which is on the outside, and the gracilis. Where's your gracilis muscle? Kind of down there somewhere, right? We're doing the crotch chop. It's like it's middle school all over again. So gracilis down below, cuneatus, think your cuticles being done because you get your nails done. I think of it, hey, the first one to branch off, it needs to be on the outside. If you're on the bus and you're going to get off first, you need to be near the exit. So this portion right here is going to branch off to my upper extremities, and that's my cuneatus. This gracilis, it's going down past my gracilis muscle. That needs to be in towards the middle because that's going to get off last. If that ends up popping up. I won't ask you to differentiate the different parts of the dorsal columns, though. All right, so let's say we have an injury at C3, which is in our neck, and it's on our right side that we get the dorsal column cut, which covers proprioception, fine touch. What do I expect to happen if I had a lesion on my right side of the dorsal column? Same-sided symptoms. What am I going to lose in my right hand? Fine sensation, touch, vibration, all those good ones. That HDMI cable, that really fine def type touch. I think that's just the answer. Sweet, love it. All right, let's say, who remembers what this one is called? I don't care too much about the anterior, posterior. This is simplified English. So it turns into the cortical spinal tract. I think they call it the lateral. Don't worry about lateral versus anterior. Just take your cortical spinal tract as a whole. What does our cortical spinal tract, where does it start? What's the first word? Cortical. So it starts in the brain, and then it goes down in spinal, so it's carrying motor, right? Because only motor goes down. We don't carry sensory down. That'd be weird. All right. So what happens if at L1, my spine, on my right-hand side, I get an injury to that cortical spinal tract, that motor tract? Which leg's going to be affected? This is going to hurt your brains for a little bit. Where does it cross over? Because it starts somewhere up here. It crosses over at the medulla, and then it continues down that same side because it crosses over up here. So on my right-hand side, if I get a lesion distal to where it's crossed over, I'm going to see symptoms down my right leg. Does everyone get that? I know it's a little bit weird. Just think about which way it's traveling. Most things cross over at the medulla. Just think of where it's traveling down. So if I get a right-sided lesion on my L1, that's going to cause my right leg to stop working quite so well. All right, and now if I get a lesion of my spinal thalamic tract. All right, so which one's my spinal thalamic? It's starting off at spinal. Where's it going to? Thalamus. What's my thalamus do? Shoots off all those weird sensations, pain, temperature, pressure. That one's going up because it's sensory, correct? Where does that one cross over? Crosses over immediately. Don't worry, I know it's our first or second time being exposed to this one. So as you see it here, it's entering. I got that sharp sensation. It's crossing over right away. The way to remember this one, think of your posterior columns, my first sensation, that's my high def one. That's my HDMI cables. They're big, they're thicker than everything else. Those things are too thick to cross over, so they go up to the same side. When I'm dealing with my cortical spinal tract, or excuse my spinal thalamic tract, those things aren't HD anymore. It's like kind of like very, like pain is like a myelinated nerve. It's much smaller than everything else. That thing can cross over right away, and that's why it does. So with that spinal thalamic tract L1 process, I'm going to see opposite-sided symptoms, aka opposite loss of pain, opposite loss of pressure, opposite loss of temperature. So damage to my right side is going to cause decreased sensation in my left leg. And don't worry, this takes a couple of iterations before it starts to make a ton of sense. So left-sided lesion, spinal thalamic crosses at the same level it enters, goes over right away. I have an injury up here. It's going to cause opposite-sided symptoms. All right. We can get what's called a central cord syndrome. This is, if you're into like the named ones, this is your first named one. We'll have a list at the end. This one affects the central part of the cord. There's a couple of different things that can cause that to happen. We can get spinal cord tumors can happen here. We can get syringiomas, which is like a little vesicle that causes issues in there. What we're paying attention to is it's affecting our spinal thalamic tracts, so pain, temperature, pressure. And because it's occurring in that central location, it's affecting where those two like to cross over. So as a result, with central cord syndrome, I'm going to get bilateral loss of pain, temperature, and pressure below the lesion. So for you guys to see, if it's up top, I might lose of my upper arms. If it's further down, I might lose those ones. Why does it only occur at that level? Because the nerves aren't traveling through the central spine, they're only crossing over at that level. That's why, hey, because this happened in C5, C6, hey, my whole body's out. No, it's only affecting the nerves are at that level because it's only crossing over at that level. Everything else is traveling up through the outside. They're not affected through that central cord syndrome. Like I said, if you guys just want to remember central cord, hey, same level loss of pain, temperature, pressure, you can do it that way. If you want to try to memorize, hey, these things cross over here, it causes this injury, and this is the result, you can do it that way too. And we have one extra course, one extra lesson in this block. If you guys want to do some review on this, we'll spend a little extra time. This is one of the harder subjects. I appreciate you guys being patient. We did one that was called hemicord syndrome or Brown-Séquard syndrome. I think we referenced it, but it was just kind of a name drop more than anything else. So what happens if I lose one half of my spinal cord? Is that a very usual thing we see? It can be, especially if we think bony fragments going in, we think someone getting shot, we think someone getting stabbed. You don't always end up with a complete transverse lesion. So we can end up with half of our spinal cord affected. So let's say we get our posterior column. What does our posterior column carry? It's the high def one, it's that proprioception, it's that fine touch. And then what's this one? Cortical spinal. So starting off our cortical, going to our spinal, that's our upper motor neuron lesion. And then what's this one right here? Spinal thalamic. It's starting off at our spinal, going to our thalamus. It's taking care of pain, pressure, all of those other weird non-HD sensations. So if we get this half cut off, below this, what kind of lesions am I expecting? We'll take it step by step. With this HDMI cable, does that cross over right away? No, it's too thick. So that's going to go up the same side. So am I going to expect same-sided or opposite-sided symptoms? Same side. Same, but different. All right. With this one, this is my cortical spinal tract, right? This one goes up and then crosses over at my medulla. Am I expecting same side or opposite-sided symptoms? So the injury's here, receptor's already crossed over, it's going down same side. It's going to cause same-sided symptoms. Does that make sense? I know the crossing over always gets people. It's like, okay, you got it? I see some yeses. Cool. And then lastly, I got this, which one's this one? Spinal thalamic, right? And that's carrying pain, temperature, pressure. That one crosses over at the level of injury, or like the level that it enters, right? So in reality, it's coming over here, crossing over and going up. So am I going to expect to see same side or opposite side? Opposite side. So same, opposite. If you can get that down, cool. And that's how you memorize Brown-Séquard syndrome. Sorry, there's a progression with that. So hemicord section happens here. Dorsal columns happen on the same side. Lateral cortical spinal tract, ipsilateral symptoms of the motor. So same-sided motor, same sorted HDMI cable, fine perception, opposite side spinal thalamic tract. You know, it's a lot to deal with. You can either memorize the name or memorize where things go, but it's just the same process for all these injuries. There's only like 2 or 3 more, so don't freak out too much. Just various ways to show it. What happens if we get a complete transverse one? Cooked. Dunion rings, as they say in the industry. We expect to see complete symptoms on both sides. That's pretty straightforward, right? So it's 2 of them, that Brown-Séquard, same, opposite, transverse lesion, all the way across, everything done throughout. And then central cord, what does that one affect? Spinal thalamic, because both of them are crossing over. Because nothing really travels up the central cord, it's just what crosses at that level. All right, this one's actually pretty easy. What about our posterior column? What does that carry? Fine touch, the HDMI cable. What happens? Can I get just an injury to my posterior cord sometimes? What if I get a really bad flexion injury and that causes that to stretch and some of those neurons not to work anymore? What can I expect to happen at that level if I end up with my posterior column syndrome happening? Yeah. It's going slowly through it. Sorry, it's dragging. I did not make this. This was here when I got here, like as a student. So if I get left and right side, what's going to happen? Fine touch in both sides below the level of the lesion. Boom. I think there was a bunch of extra things there. Don't worry about this positive Romberg's ataxia. There's a bunch of extra things in here with like spinal shock flaccidity. I don't want you to get confused with that. This is not testable. Put a big X through it. What I want you guys to identify is, hey, someone got a flexion injury, they have posterior cord syndrome, or they have a flexion injury, they have complete loss of fine touch below the level of the injury. Hey, we're describing posterior cord syndrome. Does everyone feel good about that one? That one's pretty straightforward, right? Okay. Grab the easy ones while you can. All right, if we have posterior cord syndrome, we can have anterior cord syndrome. This is where it kind of helps to pay attention to, pull it up in one fell swoop. Posterior columns carry that fine touch. What two tracts are affected then with anterior cord? Corticospinal, spinal thalamic. You guys are getting it. It's very slow. Yeah, there you go. So what's going to happen is we're going to see both sides of our upper motor neuron being affected, and then we're going to see both sides of that pain and temperature, or pressure being affected. So everything below that is going to produce bilateral, everything below, complete loss of temperature, pain, pressure, and then motor issues. Are these typically going to be the dinosaur arms or the flaccid squid arms? Because we're dealing with upper motor neurons, right? Yeah, so we're thinking more dinosaur arms. I think there was a weird slide in there, the one that I told you not to look at. Initially, they can present as flaccid because the nerves are injured and they're doing silly things. And later on, you'll start to see more of that spastic paralysis. Just in case for initial presentation, it doesn't match what you want to see. This is just like the simulations. Comparison chart, in case you guys love those ones. This is complete cord transverse section. We feel really good about that one, right? It's easy to identify. That posterior cord syndrome, that one's super easy too, right? Hemicord syndrome, got to do a little bit of thinking to figure out what's crossing over where. Anterior cord syndrome, that one's pretty easy too, right? Because it's just both sides all the way down. The two that you really have to kind of wrap your head around is going to be that hemicord syndrome, that Brown-Séquard, and that central cord syndrome, that one that kind of creates the way they describe it in tests is typically a cape-like distribution of numbness, because that's going to affect that single dermatome where they're crossing over. As long as you can bridge the mental gap for central cord syndrome and Brown-Séquard hemicord syndrome, these other three are pretty easy. So just chunk off like the easy ones and then just focus on those hard ones. And we'll spend a little bit more time on it on the review. All right, moving on from some of those spinal cord injuries, we've got cord compression. Red flags that we think of this one, think of your red flags for back pain. I think severe progressive back pain, pain that's worse at night, pain that's worse presents with motor weakness, sensory deficits, new bowel or bladder dysfunction. Those are my red flags for back pain. You'll see a ton of back pain, always ask those very similar questions. Because what we're watching out for is tumors to develop there. What's this thing in the spine, do you think? Why does it look shiny? Something that ain't supposed to be there. What's it made out of? Metal, because it's reflecting all that. And that's what metal really shows up like. You'll see it in people's teeth a lot. You guys have had radiology? Yeah, metal shows up shiny artifact. We don't show images of it because we're like, oh, that's a junk x-ray. You'll do CTs of people's spine. You're like, I'm looking for here, and people's fillings will like look like crazy, like disco lights. All right, cord compression tumors, intramedullary, extramedullary. Intramedullary means it's part of the actual spinal cord itself. Those are kind of rare. The extramedullary are the ones that are just kind of outside in that space. And these can cause issues because it can cause direct compression trauma. It can cause issues with blood flow, and then invasive infiltratory if it is the intramedullary lesion. It can travel along the nerves if it's within that space as well. All right, some of the signs and symptoms I'm looking at. Think of that radicular pain, localized diffuse. You'll see a ton of radicular symptoms and you just kind of move on with your life. Look for those red flags of like, hey, this is progressively getting way worse. This is causing people to wake up with pain. But your typical back exam, which you probably don't have a good grasp on yet, I don't think there's any real test questions. It's more just talking through how to examine somebody. All right. We talked about doing a spinal tap on people in LP. I'm not going to give you a crazy finding of like, here's what his LP looks like, make a diagnosis. Just know grossly we're looking for xanthochromtic. That means, hey, there's actual blood in there. Not just on that first tube, but all the 3 remaining tubes. It's not a traumatic tap. That's because some local tissue damage is happening for something being in there. And then we see greatly elevated protein. I thought that was weird because that kind of more fits a picture of like bacterial meningitis where the protein's super high from a ton of bacteria and exogenous stuff in there. When you actually create a CSF block, so spinal fluid normally flows down, flows back up. If we kink that off, we end up with a lot of extra sediment inside that spinal canal that can cause elevated protein. But we're not expecting signs of infection in those ones with the WBCs, and we're not expecting an elevated or normal, we're expecting a relatively normal level of glucose that shouldn't be affected like crazy. X-rays, plus or minus, you might not show the soft tissue issues. That's why we like MRI and or CT. Myelography is where they put that contrast in so you can see what's being pinched and what isn't. And then MRI with contrast is the imaging of choice. Again, if you need a stat MRI, you can get one. This is considered a neurologic emergency, so you call up and say, hey, I got spinal canal progression, you will get your same-day MRI. All right, urgent corticosteroids need to be started, and these guys need surgery because when we compress that nerve, if we decompress it, it's going to come right back, right? Depends on how long it's been pushed on, because the more blood flow is reduced from that area, the bigger problems we're going to have. The sooner you treat it, the less likely they are to have permanent disability. And comes back kind of like what I talked about. May or may not come back completely. It takes a very long time for those. But suspect it early and treat as soon as possible so you avoid disability. That's it. Oh, dang, I didn't realize it was coming up that fast. I'll hang out for a couple of questions. Does anyone have anything real quick for the group? All right, I appreciate you guys. And, hey, good luck, and I appreciate you putting in all the hard work for farm. I know it's really hard to like deal with this and ask questions, but you guys are doing really good.